Components. So we've kind of learned a little bit about testing, samples, and stuff like that. So let's speak about actually what is going into people in the components. So start with a little bit of red cell metabolism. So how do RBC survive as non-nucleated cells? So we know in their mature form, red blood cells do not contain a nucleus, but in their immature forms, they do. So basically, their time is limited when they get into their mature state without a nucleus. So we're about 120 days here, and they survive because basically their whole job is to transport hemoglobin. So without the nucleus, they actually can transport that oxygen model a little bit better. So the red blood cell must maintain the cell membrane to contain the hemoglobin, and the red blood cell must maintain the hemoglobin molecule in its functional form. And then red cells must metabolize glucose to produce the energy to maintain pH, nutrients, and waste neutralization. So for the red blood cell membrane maintenance, we have a semi-permeable membrane structure, keeps water both inside and outside of the membrane. There's a protein mesh of the cytoskeleton providing the stability, and a polar inner layer which is permeable to water. So its function is to be permeable to bicarbonate, chloride, and water, and it uses energy to move the cations, sodium, potassium, and calcium, and also contains hemoglobin. For the hemoglobin maintenance, the hemoglobin in the ferrous state is capable of transporting oxygen. Won't be the last time you see that one. Hemoglobin is maintained in the ferrous state by the methemoglobin reductase and the Lou-Behring Rappaport shunt that allows for the production of 2,3-DPG, which decreases the hemoglobin molecule's affinity for oxygen. You'll also see the 2,3-BPG, which is diphosphoglycerate or biphosphoglycerate. It's the same thing. So you may see it written with the DPG or the BPG. With metabolic system failures, decreased glucose leads to decreases in ATP, which leads to the accumulation of cations and loss of potassium and water in the cells. This causes dehydration and decreased survival. Decreased glutathione causes oxidation and decreased survival, and decreased 2,3-DPG causes increased O2 affinity. So what would you put in a blood preservative to assure survival outside the body? Food, phosphate, buffers, kind of what are we thinking here? So we do have some anticoagulant preservative solutions. These prevent clotting and extend the shelf life of the RBCs. In a standard whole blood collection volume of 450 milliliters plus or minus 50 milliliters, there's about 63 milliliters of anticoagulant. In an autologous collection, if the donor weighs less than 110 pounds, which is the cutoff weight for donation, the amount of anticoagulant must be adjusted along with the total volume of the whole blood collected. So that's one of the only times that if you can weigh less than 110 pounds, they'll allow you to donate if it's for an autologous donation. So some of the preservatives in the anticoagulant, we have dextrose, which supports ATP generation by glycolytic pathways. Adenine, which acts as a substrate for RBC ATP synthesis. Citrate, which prevents coagulation by the chelating calcium. And sodium biphosphate, which is a buffer and it prevents excessive drops in pH. So a couple different things for our blood preservatives. We have ACD, which is acid citrate dextrose, which gives it a 21-day expiration. We have citrate phosphate dextrose, CPD, which is also 21 days. Then we have units, we'll call them A1 units, which are CPD A1, which is the citrate phosphate dextrose with adenine, sends it to 35 days. Then we have the citrate phosphate dextrose with 2 dextrose, so that's CP2D, which is 21 days. And then we have 42-day additives. So we have the preservative with the additive of Adsol, which is saline, adenine, and glucose, which is SAG, and mannitol salt, which is an AS1. We have Nutrisil, which is the SAG with sodium phosphate and sodium citrate, AS3. And then the one we use the most for the additives at the blood connection, which is Optisol, which is the ASG mixture with a little bit different concentrations of our AS5. Now we do have, we use the ACD sometimes, CPDA1s, AS1s, which is the Adsol, AS3s, which are the Nutrisil, and the Optisol, which is the AS5. Those are the ones we use the most at the blood connection. So in the blood collection bag, so we're actually donating blood at this point, The primary bag contains an anticoagulant preservative mixture. The primary bag, which is attached to satellite bags and tubing in a sterile closed system. Additives contained in the attached satellite bag and added at the appropriate time in the component processing. Once entered, the system is an open system and the expiration and storage times change. Most bags are made of polyvinyl chloride, which is PVC, and these bags must be flexible, kink resistant, scratch resistant, and allow adequate O2 CO2 exchange and be transparent so we can see what's in there. So a little bit about storage lesions, which is what we talk about once blood's been stored for a little while. Um, we know that blood is stored at colder temperatures, 1 to 6 degrees storage. It can be transported up to 10 degrees, and I think we talk about that in a little bit. But when it's stored at that 1 to 6 degrees Celsius, biochemical changes occur that affect the RBC viability and function. These biochemical changes are called storage lesions. The acceptable shelf life, which is of an RBC, which says that 75% of RBCs are going to remain in the recipient's circulation 24 hours after transfusion. So with storage lesions, we have decreased glucose, increased potassium, increased lactic acid, decreased 2,3-BPG or DPG, decreased ATP, and decreased ability to carry O2 due to not letting other O2 molecules free. So when we're talking about processing these blood components, because it does not simply go from you into someone else. Whole blood is separated into components by centrifugation. Very similar to the centrifuges we're going to be using in class, but on a much larger scale with bigger bags of blood. So the RBCs are the densest and sink to the bottom. The platelets and the plasma stay on top. So we have a couple different variables that go into our component processing, such as the RPM of the centrifuge and how long we're spinning it. We have short centrifugation at low RPMs. We call those light spins, excuse me. And then we also have longer centrifugations at higher RPMs, and these are heavy or hard spins. So some steps in the blood component preparation. So we basically come into the facility with a bag of whole blood. So all your pieces and components are all there in one bag. We're going to do a light spin, and then we're going to express the platelet-rich plasma from the RBC. So we're going to spin it down. RBCs are going to be on the bottom. We're going to have those platelets up top. We're going to express it off. Back in the day, and sometimes we're having downtime and our machines are down, we can do this manually, but there's actually machines set up that do this automated, which is really neat. Be able to detect, 1 to 2 red cells themselves in these to stop when you need to keep the bags from separating. But anyway, we express that platelet-rich plasma, and then if there's any additives to add to it, it's going to add those additives to the RBCs. Then we're going to seal and cut off the RBCs. We have at that point, we have packed red cells, and we'll talk about that in a minute too. So then from that platelet-rich plasma that we expressed earlier, it's heavily spun. Then the plasma is expressed from the platelets. So we have then plasma up top of the platelets. The platelets are sealed and stored at room temperature to make random donor platelet concentrates. Then the plasma, not the please, is either frozen into FFP, which is fresh frozen plasma 24, or it's frozen and thawed to make cryo or cryoprecipitate. For whole blood, these are all our components: plasma, platelets, white cells, red cells, all in one bag. The storage of that component is going to be 1 to 6 degrees Celsius. It's going to expire in 35 days. The shipping temperature is a little bit wider range, 1 to 10 degrees Celsius. That's because we're not keeping it in that shipment for an extended period of time, so it gives you a little bit bigger temperature range on it. But 1 to 6 for storage, 1 to 10 for shipping. We're going to use whole blood for active bleeding, exchange transfusions. Some of the problems associated with this use are TACO, which is transfusion-associated circulatory overload. We also lost viable platelets and coagulation factors, and whole blood must be ABO compatible. Now, they used to use this way a bit ago, and then it kind of got out of fashion to use whole blood, but it's actually making a little bit of resurgence for when people are having emergency situations, active bleeding. They would order products in certain ratios of red cells and platelets and white cells, but kind of during research they found that if they just gave them the whole blood unit, you get the ratios built in already. These are mostly going to try to be O-POS or O-neg, depending on the facilities, SOP, and how they're going to use it. But what we'll do at the Blood Connection now is we'll actually tighter the amount of anti-A and anti-B for places in emergency situations if you're going to be getting O positive or negative blood, um, to make sure that they're quote unquote low titered, so we have less of an issue of having a minor site incompatibility issue, having that stuff going on. So whole blood's making a comeback, um, and it's working out really well for most patients. Again, whole blood's going to contain RBCs, white blood cells, platelets. These normally are not viable unless from a fresh donation. Plasma proteins. It's going to contain an anticoagulant or preservative, just keeping it from clotting up on the shelf. These do need to be cross-matched before they're given, and 1 unit is expected to raise the hemoglobin by 1 gram per deciliter and the hematocrit by 3%. Not the last time you're going to see this. 1 unit raises hemoglobin 1 gram per deciliter and the hematocrit by 3%. Red blood cells, very similar storage and shipping to our whole blood. Storage is 1 to 6 degrees Celsius. It's going to expire between 21 to 42 days, depending on that additive solution we have in there. Shipping temperature is also going to be 1 to 10 degrees Celsius. We're going to use red blood cells or packed red cells for surgical and post-surgical bleeding, oncology patients, renal dialysis patients, sickle cell anemia and thalassemia patients, and active bleeding. And probably a vast majority of our packed red cells at our facility go to sickle cell patients because they're transfusion dependent. RBCs contain, surprise, surprise, RBCs. The anticoagulant or preservative and may contain additives to extend that shelf life up to 42 days. And again, for RBCs, we need to cross-match RBCs before we give them. And an RBC, just like a whole blood, 1 unit is expected to increase the hemoglobin by 1 gram per deciliter and the hematocrit by 3%. So we can also do something a little bit with our packed RBCs. We can do something called leukocyte reduction. So the purpose of leuko reduction is in the name. We're taking those white cells out because white blood cells are implicated in adverse transfusion reactions, immunization of white blood cell antigens, cytokines or kines from white blood cells breakdown may cause febrile reactions, and that happens sometimes. But it's also going to reduce the CMV transition rate. So sometimes people may ask for a CMV negative unit. Depending on how many we test and how we may not have a CMV negative unit, but we can say that a leukocyte reduced unit is CMV safe because it reduces that CMV transmission. You can do a couple of different ways to leukocyte reduce products. You can do pre-storage filtration, like at our facility at Blood Connection. We hang our units, or they can be done while they're being collected. And you can also have a bedside filtration. But most places are going to, order them pre-storage leukocyte reduced, meaning that after the packed red cells are done, before they get processed and all the other, they're going to be leukocyte reduced first. So the QC standard for leukocyte reduced products is we're going to need to maintain a minimum of 85% of those red blood cells, and we want less than 5 times 10 to the 6 white blood cells. And, we do QC on these to make sure that we pick some random units, a certain number based on how many we've collected for the month, and make sure that these are going to pass these requirements. In the actual process of donating blood, you can do something called red cell pheresis. It's also called a double RBC collection. This is collected by automated pheresis equipment. You can donate every 16 weeks as opposed to longer with a whole blood donation. Fluids are given to the donor to minimize fluid depletion. Very helpful in inventory management, especially when we start talking like O negs and you're getting low. We always recommend the O negative people, if they can, to give a double RBC collection. For the pheresis with the red cell, they're really just pulling out what they need and putting back what they don't. A lot of times they're pulling out the platelets and pulling out your red cells, but they're putting your plasma back into you so you can donate more frequently. It's an interesting process. So you can also freeze RBCs. So a couple reasons we may want to freeze RBCs is that we have a rare unit. We may have a unit that we talked about before that's the 1 in 20,000, the 1 in 50,000, and we want to have it in case someone needs it for a rare issue. We actually have these places that are signed up through rare donor registry programs, and people put requests out all the time. Do you have this unit? And that's something we can do for that. It's also going to extend the shelf life of an autologous unit if someone needs it, particularly for a surgery or something. But it can be stored for up to 10 years at negative 65 degrees Celsius. So we can't just freeze RBCs, can't just toss them in the freezer and hope for the best. We must add glycerol to the unit, which is a cryoprotective agent to prevent ice crystals in those RBCs. Because if we were just to throw an RBC in the freezer, it's going to look great until we go to thaw it out, and then those ice crystals have hemolyzed all our red cells, then we just got a big hemolyzed mess. So for deglycerizing those RBCs, and it's kind of the same fact that if we're going to add glycerol to the RBCs, we can't really transfuse someone glycerized RBCs. So when they're thawed, the glycerol must be removed because it is toxic to the patient. The unit is thawed in a 37-degree water bath with decreasing osmolar saline solutions. If the unit is thawed in an open system, it expires in 24 hours. So basically, if it doesn't remain closed, meaning it's going to be exposed to the environment in some way, it's going to expire in 24 hours. But if it stays in a closed system, it's going to expire in 14 days. We can also wash RBCs. We have cell washers that do the same function as deglycerizing those units. We're washing that glycerol off their RBCs. We can wash RBCs for patients that react to plasma proteins. These are usually IgA deficient patients with clinically significant anti-IgA. They're washed in, again, the same manner as the deglycerized units. You do experience a loss of about 10 to 20% of RBCs. This is not an effective method of leukocyte reduction. So even if we wash it, we still maintain some of those white cells. And these go from basically rectangular-ish looking bags to odd looking donut bags. So it's interesting to see a wash cell bag. Hopefully I can show you guys a picture. We can also irradiate RBCs. And so the irradiated RBCs are going to prevent proliferation of T cells, which we talked about before, which helps prevent the transfusion-associated graft versus host disease. This is going to be required for HLA matched products and units from first-degree relatives. They'll also use it with people who have who are immunocompromised, such as cancer patients. Sometimes they'll ask for irradiated RBCs. One method of irradiating uses gamma rays. The dose of this irradiation is 25 rads or 25 grays. Most places outside of U.S. use the GY amount or the gray amount for the dose. We have recently switched in our facility from using a gamma irradiator to an X-ray irradiator, which for us allows for more units at one time, and we don't have to go through Homeland Security like with the gamma irradiator due to the potential to make a dirty bomb or something. So the room was monitored. You had to get retinal scans and fingerprints, and it was something serious. But now, since it's just a plain old X-ray, we don't have to do any of that, which is awesome. It actually also cut the processing time down significantly between using the gamma irradiator and the X-ray. So the AABB recommends irradiated products for intrauterine transfusion, again, immunocompromised or immunodeficient patients, allogeneic bone marrow or peripheral stem cell transplant recipients, premature infants, and patients undergoing chemotherapy or radiation treatments. So the irradiation of the RBC damages the membrane. It's going to cause a higher potassium level and a decrease in the ATP and the 2,3-DPG levels. Now, the higher potassium plasma levels is minuscule. They consider it not clinically significant. It's going to be very similar with the gamma or the X-ray irradiation. The expiration changes to 28 days from the irradiation or the original expiration of the unit, whichever is first. Irradiated units can be transfused to anyone if the original recipient no longer needs the product. Let's say they originally ordered 5, only transfused 3. No harm is given to an irradiated product to an immunocompetent individual. So moving on to platelets. We're going to give platelets to control or prevent bleeding associated with critically decreased platelet counts or functionally abnormal platelets. Most of these patients are going to be cancer patients that are on chemotherapy or radiation treatment, post-bone marrow transplant patients, or post-operative bleeding. Platelets are going to be stored at 20 to 24 degrees Celsius, which is room temperature. They have a hard time storing platelets for the most part at refrigerated temperatures because they like to coagulate at that temperature, but not out of the realm of possibility, maybe in the future. To extend the time frame on it, because platelets are only going to be viable for 5 days right now. They're working on some updates with the technical manual to get it up to 7 days, but currently it's 5 days. And through the course of giving someone platelets, they may become refractory, which is just saying they're unresponsive to platelet transfusion therapy. You could have someone that has been getting good bumps from platelets, and that's what we say when they're getting a good platelet increase, and then stop becoming responsive to it, and we'll say they become refractory. This refractor may be to immune or non-immune reasons. If we looked at the chapter summary of chapter 11, it's on page 273, it's going to kind of go into just a couple details between what's an immune-mediated or non-immune mediated complications of transfusions, just to kind of look that over a little bit. So we can also look at the corrected count increment, and the CCI determines the increase in platelet count adjusted for the number of platelets infused and the size of the patient. No cross matches required for platelets, and we're going to do ABO matched if possible, but an ABO compatible is their second choice. We also can give a random type above if the choices are not available, because we're talking about platelets here. We're talking about cell fragments rather than full-on cells. So we're not as worried about having strong reactions for giving something that's not compatible, but we want to give matched or compatible if possible. So a couple ways to get our platelets. One's going to be from random donor concentrates. So platelets can be prepared from a unit of whole blood, like we talked about before, and we want at least 5.5 times 10 to the 10th platelets per unit. This should increase the platelet count by about 5,000. This is stored like our regular platelets at 20 to 24 degrees Celsius for about 5 days from collection with gentle agitation. So remember, the whole point of platelets is that we want to clot and we want to keep things from bleeding. So we want to keep them from doing their job in the bag by keeping them constantly moving. For the pools, platelet concentrates are pulled together to achieve a therapeutic dose. If we're using an open system when we're pulling it, it's a 4-hour expiration. This method is not as used as often as the method we're about to talk about, and it will also change a little bit about how the doctor is going to order a unit if they're slightly confused with how the platelets are collected. So most platelets now are going to be single donor pheresis or single donor apheresis platelets. So an apheresis is an effective method of harvesting a therapeutic dose of platelets from one individual. Whole blood is collected from the donor, and platelets are separated into separate bags with all the other blood products returning to the donor, very similar to a double red cell collection. These are going to contain a minimum of 3 times 10 to the 11th platelets. The storage for this is like, again, regular platelets. It's going to be 20 to 24 degrees Celsius for about 5 days. So we can also do a apheresis platelet and do an HLA matched apheresis platelet. This is going to be indicated if the patient is refractory due to HLA antibodies. We're going to match them for class 1 antigens, and this requires advance notice to the blood center because we need to have our patient HLA typed. We recently started doing this for people that were refractory. You can also do something called a platelet cross-match. Going to be similar to a red blood cell cross-match. In a similar methodology, we use our solid phase methodology to get to see if we think a platelet's going to be a good match for someone. And at this point, when they're ordering HLA matches, is we have our random donor apheresis units weren't giving them a great bump. Our platelet cross matches aren't giving them a great bump. So we're going to have to send the patient off at this point to be HLA type, but we're hopefully working on how to do that in-house with molecular. I'm holding my breath. Once we get the HLA match, we want to try to find donors in-house that are going to be good matches for these patients, and hopefully that fix what was causing our refractoriness. Platelets are also leukocyte reduced. The reduction is done using a filter, either pre-storage or at the bedside, and must have less than 5 times 10 to the 6 white cells in the package. This is indicated to prevent recurrent febrile non-hemolytic reactions and HLA alloimmunization. It reduces the cytokines, and it's effective in preventing the CMV infection, also called CMV safe, just like a leukocyte reduced RBC. When we're doing these donations, we have it set up so that we can have leukocyte reduced platelets during collection. So fresh frozen plasma. It just me thought we were done with coag. This is going to be indicated for coagulation factor replacement for factors 2, 5, 7, or 11. Coagulopathy from massive transfusion. Also for the reversal of warfarin therapy in emergency surgical patients. So if we have someone who is on this blood thinner, we want to give them the fresh frozen plasma so we're not bleeding, especially during emergency surgery. We can also use it for bleeding complications in patients with severe liver disease. We can use people that have DIC or disseminated intravascular coagulation with fibrinogen levels of less than 100 milligrams per deciliter. We can use it for the treatment of TTP and HUS, which we want to use cryoporoplasmin for that. TTP is thrombotic thrombocytopenic purpura, and HUS is hemolytic uremic syndrome. Both of these have low platelet counts, renal dysfunction, some central nervous system involvement, and hemolytic anemia in small blood vessels. So a little bit of difference between the FFP and the FP24. So the FFP is made from whole blood within 8 hours of collection, and the FP24 is made from whole blood within 24 hours of collection. The FFP is going to contain all the coagulation factors, including 5 and 8, and the FP24 is not a good source of the labile coagulation factors from not quite getting it processed in enough time. The FFP and the FP24 both can be stored for negative 18 degrees Celsius for up to 1 year. The way we get them once they're frozen is we're going to thaw them in a 30 to 37 degree water bath for about 20 minutes. We want to protect the water from contamination with a plastic overwrap. So we got a little separation there. They're stored after thawing at 1 to 6 degrees Celsius for 24 hours from the start of the thaw. No cross match is needed for these, but they need to be ABO compatible. So we also have cryoprecipitated antihemolytic factor, or cryo. This is for supplement from factor 8 and fibrinogen deficiency, or factor 8 replacement if it's unavailable to be made up from the pharmacy. This contains von Willebrand's factor, which is needed for platelet adhesion, fibrinogen, factor 8, and factor 13. So for the QC of the cryo, is it must demonstrate 150 milligrams of fibrinogen and 80 international units of factor 8 per unit tested. So the cryo is stored at negative 18 degrees Celsius for up to a year. This is not really routinely kept in inventory in all hospitals. We definitely keep it routinely in inventory at the blood collection and blood donation centers, but not routinely kept in the inventory of the hospitals. They'll kind of order it when they need it. You can also pull these, so it's frozen units are thawed in a 30 to 37 degree water bath for about 10 minutes using that plastic overwrap. Saline can also be added to rinse the units and combined to form a therapeutic dose. ABO compatible units are recommended, but not 100% necessary, but definitely recommended. The thawed cryo is stored at 20 to 24 degrees Celsius, and with an open system, it says a 4-hour expiration. You can purchase these pre-pulled with a slightly longer out date on them. This is an interesting one. So fibrin glue from cryo, also called topical cryo. This is used to control bleeding during surgery. It's used in aortic surgeries, patch grafts, CSF leaks, cosmetic surgery, nasal narrowing surgery. It's also used in minor surgery and tooth extractions in special populations. 1 to 2 units of cryo are mixed with thrombin and applied to the site. Most often this product is purchased commercially as ready to use. So everything's been done to it. You're really just kind of purchasing it, as a reagent. You can also transfuse granulocytes with an apheresis granulocyte product. We don't use these a whole lot. They are prepared by hemopheresis or an apheresis collection. These contain white blood cells, platelets, and 20 to 50 milliliters of red blood cells. We're going to store these at 20 to 24 degrees Celsius. It's 24 hours from the time of collection, so it really limits that product's usefulness. So once we collect it, we've got to use it. A crossmatch is required due to the amount of RBCs that are in the product, and we have to remember not to use a filter to remove the leukocytes because the purpose of this is granulocytes, and we're going to irradiate it to prevent graft versus host disease. So speaking to labeling of blood products, so we've gathered and manufactured and processed what we're looking for. So now we're going to label it properly. This process provides a final check of records, QC, donor testing, modification, and labels. If we look at page 361, so for some label requirements, is one, obviously the donor identification number or the unit number itself. We want to know the ABO and RH blood group of the unit. Some labels may have a collection date, but it's not 100% necessary. Um, we also want to have a product code, and product codes are going to be tied to what product we're looking at as well. We definitely want to have the expiration date, sometimes and time of that. Mostly it's just a date. And we can also have some special testing done. Here is where if we needed to have antigen negative red cells, where they would show up on the label, or if you had CMV testing done, it would say, negative for antibodies to CMV. Irradiated products must list the name of the facility performing and show proof of the irradiation. You can't just say it is irradiated. We got to have a little monitor on there that says it's received the proper amount of irradiation. Pooled components must include the final volume, the unique pool number, and the name of the facility preparing the component. And autologous units must be labeled for autologous use only, so they can't go to any other person. So as regulated by the FDA, the AABB, and CAP, for storage, all refrigerators, freezers, and platelet incubators must have a recording device to monitor the temp at least every 4 hours, audible alarms to ensure response 24 hours a day, alarm before an undesirable temperature is reached. So basically, if your unit is good in storage from 1 to 6, your alarm needs to go off before it hits that temperature. We want to have the alarm checks performed regularly. We do ours every quarter to make sure it's alarming properly. We will also have emergency procedures in place for power failure and alarm activation. We need to have emergency power systems and continuous power source for the alarms, such as a battery backup. We use calibrated thermometers to check against reference thermometers to make sure that everything is what it says it is. And we also need a written procedure for all of the above this for our monitored refrigerators. So when we're storing our blood products, especially our red cells, we're going to check our inventory daily for evidence of molysis, evidence of bacterial contamination, and our expiration dates to make sure we're not expiring units on the shelf. And we want to have a sufficient amount of segments for testing, so we need to have at least 2 integrally attached segments for our testing purposes. So transporting blood products, these must be done in validated containers. So we have to basically put them through some rigorous testing to make sure the temperature is going to stay where it is for as long as it needs to. These also must be shipped under the appropriate conditions. So whole blood RBCs, shipping 1 to 10 degrees Celsius. Platelets maintain that same storage temperature. It's 20 to 24 degrees Celsius. And fresh frozen plasma and cryo needs to be shipped on dry ice. So basically, we want it cold enough that it's not going to thaw in shipment. But that's exactly how we ship them at work. So we're also going to get a receipt from a blood center or a receipt from someone from the Blood Connection that sent it to you. So the temperature and the appearance is checked and recorded. The shipping records are checked for accuracy. And if anything is unacceptable, we're going to document, quarantine the product, and return it to the blood supplier. So let's say you get the blood in, you temp that blood, and it's 15 degrees Celsius. Well, that's out of realm of that transport of 10. So we need to document that it was out of temperature, quarantine the product so there's no way it can be transfused at your facility, and hopefully going to come back to us to go, hey dude, your cooler's supposed to be validated, but this came in out of temp, and then we kind of had to do some investigations to see why that happened. So once we're going to issue the blood products, we're getting down to the nitty gritty now. We're going to recheck all of our records, make sure things are compatible, going to the right patient, all that stuff. We're going to look at the proper patient ID to make sure everything matches. We're going to have a trained transporter to take the blood to where it needs to go. We will retain some segment or segments as a pre-transfusion sample, so if we have any sort of transfusion issues, we have at least something before we transfuse them to go back and look at. And we also need to have a policy in place for the number of units we can issue at one time. And lastly, for the administration of our blood components, some of the requirements is to need to have a positive ID of the patient and the blood sample, a system to avoid and detect clerical errors, a direct observation of the patient during and after transfusion, so we're not just going to leave them to their own devices. Only normal saline should be administered with blood products, or an FDA approved solution. So it can be other than normal saline. We're going to use a proper 170 micron filter. We need to infuse the blood product within 4 hours. And we're going to make sure our documentation record keeping are as accurate and complete as possible. So a good bit here with blood components, but we definitely need to know storage for blood components and expiration of our blood components as well. So we will see you next time.